Recording has started. Thank goodness. I didn't record the last one.
Oh, no.
Well, I get on early and I was setting up things and I still have trouble with Teams. And so I was messing with it and I paused the recording and I thought I went in and told it to start again. And
No.
I hadn't. I screwed up.
Well, Teams is so touchy. I just don't touch anything because it turns something on or turn something off. I get kicked out of the meeting. It's very persnicky or whatever. Yeah.
Yeah, well, we're so used to the other that we've
And
used.
that was really seamless now that I think about it.
Yeah. Crazy, but anyway, no, I'm down in Albuquerque with Aztec, the Aberdeen area epicenter, and doing a tribal introduction to grant writing, a basic
Oh, that's going to be
class.
a gift
Yeah,
to them.
it's
Yeah.
fun.
Yeah.
People, really good people. So
I
nice.
like that group. They're really good.
Yeah.
Yeah. They're very good. Yeah, we're getting some snow out here. It's starting to, we're supposed to get
Oh,
about an inch down. I don't know how much we're getting your way, but we're getting an inch here. That's what they say.
yeah. Rick thought first they thought that we were going to get some, and then he thought it wasn't, that we weren't going to get it. And we're waiting for the guy to come up and cut, they're cutting 156 trees that are within 100 feet of our house for firewise
Oh,
safety.
for fire prevention, yeah.
Yeah. And most of them are small trunks, less than 6 inches in
Yeah,
diameter.
they're not that big up there. No.
No. But a few of them, we've got one that's huge. And he
That's why you
can't
got to
come
hire
while
somebody to
there's
do that
snow.
stuff. Just saying, better
Yeah.
to hire somebody. They know what they're doing.
Hey, Marianne. Hello.
Hello.
How are you doing?
Good, thank you.
And what time is it in the morning there?
Pardon?
What time is it in the morning for you?
It is
What time do you have?
12:50. It's 1 o'clock day.
Okay, 1 o'clock. We are 5 in the afternoon. Yeah.
Wow.
So welcome. You haven't been on one of our iPins before, have you?
No. Cancer WHIRI.
Uh-huh. Wonderful. Yeah, we're going to highlight your program today, I believe, or part of your program in New Zealand, part of what's going on with Maori. So it'll be good. And also with Australia. Is that a baby or a puppy?
It's a puppy. Bombing us.
Is that new, Corey?
I call him a puppy, but he's actually just a little dog. It's my mother's dog, and he's definitely a baby. Let's just say that in mentality. Right? He's spoiled. He's very spoiled. He loved to Zoom on me. I don't know what that is. It's just if I got a Zoom meeting on.
I get it. And how are your classes going?
Oh, fast. University of Denver, the quarter system just ended. The semester is going to be in about, Thanksgiving. Forget that week. Nobody does anything. And so it's like 2 weeks out, 3 weeks out. I'm pushing it. But it's good. They're great. I love it. I love teaching.
So Marianne, you're getting some help. What troubles are you having?
Videos checking.
Okay, if you have your cell phone on, it will cause an echo. So your audio should be coming through your computer to avoid the echo. And who's this young, lovely young lady helping out? Hello? Hello. We're still getting an echo from you.
Oh, there we go.
Hello, Gail.
Hi, Linda. So nice to see you.
Oh, so nice to see you too. How are you doing?
Oh my God, I can't wait till the end of the year.
Well, at least the book isn't hanging over your head now, right?
Oh, yes, that's the bonus. That is great. I tell you what, we've had so much interest in that book. I'd like to check how many Springer have downloaded or sold. Yeah, yeah.
Oh, good. You know, we have a lot of people in the States, authors, who haven't received a copy yet.
Oh, so that we just have to, whoever's the lead, they get a copy. And, we checked with Springer and they said, no, everyone's got a copy. And then we got emails from some individuals saying, actually, they don't have a copy. And they said, oh, they didn't give us the proper address. It's like, well, no, they didn't get a copy then. So
Yeah.
if they can, if you know people who haven't received a copy, they just have to reach out directly to Alicia or whatever her name is.
Aurora or Aruna.
Oh, an
Yeah,
A something.
yeah. I have it in something, but a couple, contacted and I said, well, I know some have received it and some haven't. So
Yeah, and I know I didn't get my book till well after we were in Geneva, where other people had already received some of those stuff. Yeah.
well, yeah, and that was September.
Yeah. Yep. Yep. But I'll try and find, but it's that email.
Oh, don't worry about it. I'll
Okay.
follow up with other people. I've just been spread kind of
Yeah.
nuts too. You know how it is. And so
Yeah.
and some people have said, oh, what do we do? And it's like, all right. And hello, we have a few more people joining us, Laura and Shannon. Hi. And go ahead
And
and say,
these ladies are from my team, and Shannon's presenting to one of our presenters today, but I'll let them introduce themselves. Yeah.
excellent, excellent, good. And we're still a few minutes early, so we'll wait. We usually wait until about 5 after the hour. Yeah. Or in some of your areas in Australia, 5 after the half hour,
Yes.
the bottom of the
Oh,
hour.
I know. It's so tricky. We have like about 3 different time zones and trying to work that out. Yeah.
Yeah. Yeah, we have about 5, because Hawaii's a couple hours behind the Pacific coast, and they're an hour behind the mountain region, and
Yes.
that's behind the central region, and then there's eastern region. But we're all full hours. You have half hours, there that
Yeah.
it's a
Yeah,
challenge.
between like Darwin and here. Yeah, yeah.
And we got Christy now. Hello, Christy.
Hello, it's Kirsty. I'm just connecting in from New Zealand.
Excellent. Welcome. Welcome. Very good. Very good. And we have notes from people who say, oh my gosh, I so want to hear this one. And I screwed up on the recording last month for the iPin.
Ah,
So upset. So many people have asked for the video. And it's like, I'm sorry, I messed up on the recording. But this one's recording. I'm not messing it up.
okay. Good on you.
Oh, even being techno Indian, yeah. Sometimes you need some technical assistance. Hey, Sandra, you got a puppy. Who's helping you?
Yes,
How are
this
you
is
doing?
Vickie. He's like the office dog now. He likes it in here.
Well, since COVID, there are a lot of offices that now have dogs. And they're well behaved. It's pretty wonderful.
Yeah.
Anything fun and social anyone wants to share while we wait for a few more people to connect?
I'll just add that I am going to have to apologise because I actually have a meeting off-site, so I'm not going to be able to stay for all of Gail's talk if she's second, but which I would love to hear. But anyway, so I'll just disappear quietly. And I'm glad that you've got the recording sorted.
Oh, me too. I'm so embarrassed that I screwed that up, but things like that happen.
Yeah. And Sandy, just so you know, Shannon and Amy from our team will be presenting today. Actually, I'm really grateful not to be presenting. We've had our national cancer conference last week. We've got our GI cancer this week, and I've done quite a few presentations and got to go back in this afternoon. So I'm very happy not to do any presenting today and hand it over to Shannon and Amy's capable hands.
Okay.
Hey, Nina.
We have some part of our New Zealand team has joined us too. Wonderful. So we have Nina and Tina and Amy, Aiden, WHIRLI, woohoo, Kanita. Excelente. All right, good job. Well, let's go ahead and get started. It's only a few minutes after, and let's allow people to briefly introduce one another so that you can tell where they are from. For those of you who haven't been on an iPin with us before, we're very informal. We do use slides to help explain things. I do request that the speakers send me the slides so I can post them to the website, take out anything that needs to be private. That you don't want to share, that's fine with us. We do record the session because we are on 24 different time zones for our iPin. A lot of people rely on the videos to be able to catch up and move forward in a good way. And let's go ahead and start with some introductions. So Corey, would you please introduce yourself? Kind of tell us what your name, your tribal affiliation, if you have any tribal affiliation, and what you do related to patient navigation, please.
Yatae. My name is Corey Santos, and I am Apache and Diné Navajo from the Southwest. I actually have worked with Linda B for quite a few years since my dissertation on Native patient navigators. So I've been working with patient navigation and Native, in particular Native patient navigation since my dissertation. I'm actually a navigator as well. So welcome everyone.
Thank you, Corey. Marianne, would you go ahead and introduce yourself? Marianne, we're having trouble with your audio. Do you see the little chat box? Would you go ahead and put your name and your information in the chat box? We're getting a really big echo. I'm so sorry about that. Okay, and while she's doing that, Gail, go ahead and introduce yourself, then we'll come back to Marianne.
Yeah, thanks, Linda. I'd just like to acknowledge the traditional lands in which we're meeting on today here in Australia. So I'm on the lands of I'm in Meerjin, which is Brisbane, on the lands of the Jagera and Turrbal nations. I'm Gail Garvey, a Kamilaroi woman, and I'm currently heading up a research program that focuses on cancer and Aboriginal and Torres Strait Islander Australians, and patient navigation is one of the projects that we're doing, and we have Shannon and Amy presenting on that today. Thanks.
Thank you very much. And we have an RN read our meeting notes. I don't know who that is. It's on mute. Anyone
It's
know?
an AI chatbot thing to take notes.
Oh, okay. I see. Well, thank you. Well, Nina, go ahead and introduce yourself, please.
Kia ora te whānau, ko waio, ko te iri o Ngāti Whātua Ngā Puhimi Waikato. So my tribes are from the middle to the top of the New Zealand, and I am co-chair of the amazing organisation called Hei Ahuru Mōwai, which means a sheltering haven for all, and it is the National Māori Cancer Leadership Group here in Aotearoa, New Zealand. Kia ora.
Excellent. Thank you very much. Laura.
Hi, my name's Lara. I'm the project manager with Gail. So working with Shannon and Jay, that will be sort of supporting them in the project research part of their role.
Wonderful. Thank you and welcome. Shannon.
Hi, I'm Shannon. I'm a Pita woman, and that is from up in the top of Queensland. And I am the clinical nurse consultant for cancer services at one of Queensland's largest hospitals. And I am in the research project that's being run by Gail.
Wonderful. Thank you. Welcome.
Thank you.
Kirsty.
Tēnā koutou katoa. Greetings from Aotearoa, he uri ahau o Tapuika me Ngaitai. My iwi are from Ngaitai and Tapuika in the sort of centralist of part of the North Island. And my role is CEO of Potiri, and we're really blessed to be one of the cancer care coordination services in the Bay of Plenty.
Excellent. Excellent. Sandra.
Oh, hi, Linda. Hi, everybody. I'm Sandy Thompson. I'm based in the Midwest region in Geraldton in Western Australia, and just have a long-standing interest in improving Aboriginal cancer outcomes.
Thank you very much. And Kanita.
Kia ora koutou, ko Kanita Nikora taku ingoa, he uri hau no rongo whakaata Ngāti Ruenui me Ngāpuhi. I am the operations manager at Hei Ahuru Mōwai. So my iwi are on the west coast and the east coast of the North Island of New Zealand, Aotearoa. And our role is to provide some national coordination and support services out to the amazing 20 hauora Māori partners that are delivering cancer navigation services. So great to be on board here today. Kia ora.
Excellent. And how about Amy?
Kia ora koutou, ko Amy Jones taku ingoa. So I'm Amy Jones. I'm from Aotearoa, New Zealand. I'm tangata tiriti, so I'm a New Zealand European who supports and is part of the Treaty of Waitangi in our country. And I'm the research program manager at Te Whatuora Waikato, so I work with Nina on our Māori health equity research there. So kia ora, thanks for having us.
Thank you very much. Thanks for all of you being here. Tina.
Kia ora koutou. I didn't expect an intro, so thank you, Linda. I whānau mai ahau ki Taumaranui, a hiri ahau o Kaitahu, ko Tina Nikora. I work with Amy and Nina, and I support Heiura Mowai with the mahi that they do. That was my auntie Gretchen that was just in the screen here before. She's the auntie of Nina and I, linked through our dads who are brothers. So there you go, a little bit of whakapapa there for us. Thank you, everybody.
Wonderful. And Shirley.
Kia ora, I'm Ko Shirley Gardner, aho taka ingoa. I'm from the beautiful Aotearoa, and I live on the west coast, which is in the South Island, the west coast of the South Island. My is with Potini Waiora, who are partners for the cancer care coordination services here on the west coast, and we provide lots of support to whānau who are and on the journey, I guess, and we do a lot of preventative work as well. So kia ora.
Wonderful. Thank you very much. Joanne.
Tēnā koutou katoa. Oh, can you hear me?
Yes.
Oh, okay. Tēnā koutou katoa ko Ngāti Kahu Ngāi Tahu Ngāti Tarara o Kuiwi, no Muri Whenua hau, ko Joe Ellis tōku ingoa. My name's Joe. I live in the beautiful far north of Aotearoa, up in Muri Whenua, right at the top there. My whakapapa is both to Ngāi Tahu from my grandmother, so Kraitiana from there, and my grandfather is a reihana here in Ngāti Kahu, and also part Croatian, so you know, foot in each island and one in the north, in the northern hemisphere. I am the general manager of community programs and outreach at Te Huku Hauora, a Māori health provider here, and I oversee and manage the cancer coordination care services here in Muri Whenua.
Excellent. Excellent. And Jay.
Morning, I'm Jay. I'm the Shannon of, I'm doing the same role as Shannon down in the PA hospital. I'm living in Cairns in far north Queensland. I am a Māori woman from WHIRLI from New South Wales, but living up here in sunny Cairns.
Thank you. And Marianne, should we try again? Let's see if we can get your audio going.
Okay, so kia ora koutou. My name's Marianne Clarisic, and I whakapapa to Ngāpui Te Raroa and Te Aupōuri. I live in Autonomy, which is up the top of the North Island. I'm Māori and also Dalmatian Croatian. I am the cancer care coordinator for our area, which is about 70% Māori, isolated, rural, high deprivation communities. And we provide services from health promotion through to end-of-life care, as well as chronic disease management.
Excellent. Thank you so much. Welcome. Welcome. Christine. Christine, you're on mute.
Yes, kia ora, tēnā tātou. Sorry I'm late. Very lovely and honoured to be here. So I'm a health equity evaluator in the Health Services Research and Evaluation team in Te Whatuora, and I'm just here to listen in there. Tēnā tātou.
Welcome. Did I miss anyone? Okay. Then I welcome all of you. I'm Linda B. or Linda Burhans-Stepanoff. I'm Cherokee Nation of Oklahoma. I have worked with Indigenous cancer issues since the actually early 1980s. And I'm very happy to be able to host and facilitate this gathering. Oh, we got Bubsy back. Let's have Bubsy. Bubsy, are you there? She was on and she's off again, and hopefully she'll join us again. We're going to go ahead and for everyone who's not been on this before, we're very informal. This is a group where we're Indigenous people trying to help one another with their patient navigation program. We like to share strategies that have worked in your setting that may be of assistance to people working in another country and in another setting. So we're looking for wonderful proactive ideas. If you are having issues or problems, feel free to share those too, because frequently other people who are on the call have ideas of how to address and how to approach whatever challenge may need to be. So we are very much a support network for Native patient navigators, even though we go by different names in our respective countries. So we're going to have two programs shared with us today. And the first is going to be from New Zealand. And let's go ahead and Nina, who do you want to start off for New Zealand? And you can share your screen also.
Yep. Kia ora, Linda. So it's Amy and I are going to kick it off, and then Robin, our National Māori Cancer Care Coordinator nurse lead, is going second. But Robin's on a plane on the way to Fiji for a beautiful and well-deserved holiday. So I'm going to be Robin. And then we've got Kirsty, who's on the screen from Potiri Trust, who's going to give us, you know, what we all want to hear from as people who are on the ground. So there'll be three of us. So we'll walk through the slides. How long have we got? We've got like 30 minutes. 45, you said? Yeah. Oh, you're on mute.
Thank you. 30 to 45. Whatever you need. Okay.
Okay. So tēnā rā tātou katoa. I think many of you have heard about our Cancer WHIRI program, which is our model of care for cancer navigation and support for whānau Māori or Māori and their families who are going through cancer in Aotearoa, New Zealand. Amy's going to try and, Amy's managing the slides. We've got a little thing. I'm going to flick my hand and then Amy's going to do the slide. And we want to dedicate this presentation to Steph, who was one of our co-design whānau members who helped us design Cancer WHIRI and who was very, very directive right throughout our process. And Steph was well known nationally and internationally as a sign language pioneer. So kia koe, Steph. So we all know the stats, we all know why we're doing this. We have unfair cancer stats due to colonisation that's ongoing and never stopped. Next slide. And we don't just want to do research, we actually want to change the way cancer services are delivered. And we've been very frustrated with recommendations. They seem to go nowhere. We've been trying for decades to change the way cancer care services are delivered in this country. And so we ended up just trying to do it ourselves. And one of the really good ways of making change is through research. Because if you can convince research funders to fund your research, then you have a protected time and you have protected staff and protected funding. So in this case, I think we had, Amy, was it 2 years or 3 years? Three
for this project.
We had 3 years and about $1 million to do this project. So next slide. Oh yeah, it says on there 3 years. There you go. Goodness me. So the goal was, I mean, this is not rocket science. This is all stuff we know. It was to co-design a cancer pathway, a model of care. And we were initially thinking we'll do the whole cancer care pathway, and then we thought no, let's chunk it down, let's do it really well, test it, show it works, and then we'll do the next pathway. So we did that. And this was to go from the time that people are referred with a potential diagnosis of cancer through to their first treatment, because we know that's a problem period and there's massive time delays and, you know, services fail Māori whānau right here. So we thought, okay, we'll start there at the start and we'll use our Māori implementation framework, which kind of tells you what to do. And once again, that's not rocket science. It's all about community engagement and developing good relationships and letting empower sharing. And we knew we were working well when Steph took over and said, no, you've got to do it this way. And our other whānau took over. And you can see Vonda scribbling on the wall there and taking charge. So next slide. And we have developed very deep lifelong relationships with all of our, actually they all ended up being wahine, so women with cancer, and actually they were diagnosed with cancer or had cancer treatment during COVID, because that was part of our study. This is somebody hasn't got their mute on. Maybe, there you go. This is the model that our co-designed model. So we designed a model, and these were all the most important things that we came out with. It was co-created between individuals and their families with cancer, all Māori, and Māori cancer specialists and other subject matter experts. So next slide. And then that took ages. That took a long time to establish our co-design team and design the pathway. And I'm going to hand over to Amy to talk about the technical study part of it, where we actually recruited 34 Māori patients referred to the hospital and what we did from there. So.
Sorry if you pick up some background noise, it's some work going on around me. But yeah, so we tested the Cancer WHIRI model, and we'll show you what that model looks like in a minute. But we ended up recruiting 34 Māori patients. We had a navigator there, Helena, and a wonderful nurse, our WHIRI nurse Ash, who supported all our whānau that were going through the research trial. And we developed and did a patient experience survey at the end as well. And our approach based on feedback from our whānau and everything that we knew, we used the Meihana model, which is a Māori model of health. So part of the WHIRI process is to use what we call the whā tool, or the whānau hauora assessment. I'm not going to go over all of it, but this is just showing you the model, and this is all the areas or topics, health and wellbeing topics that were covered in the tool. It was a scripted screening assessment with follow-up pathways and protocols to support any identified need when going through the screening questions. And the screening questions were all reviewed by whānau. They were developed with our co-design and our subject matter experts as well. So you can see we're covering a huge range of topics there. And this is sort of a nice example or infographic of what the WHIRI pathway looks like. So a referral comes in for a suspicion of cancer, and we pick up the details of them being Māori and referred, usually by a GP, and our nurse does a note review and make contact whānau at that point to support any clinical issues, and generally that tends to be around comorbidities. Our navigator calls and does a VAR over the phone, and for our study that was usually face to face, so they made a time to go to patients' homes and conduct that, and then referrals went out to services that were primarily community-based services that were already existing, so we're just navigating them to things that they weren't aware of for the most part. Is there anything else you want to say about that process, Nina?
When we were developing up the whā tool, so the screening questions and the follow-up protocols, we looked quite widely, including, and I think we borrowed a lot of Gail's, we looked through Gail's publications around, you know, and anything we could find internationally around Indigenous cancer navigators and needs, yeah. And it's constantly updated, the whā tool. So next slide. So we found, as you would expect, multiple unmet needs from people who were referred with a suspicion of cancer, and that was the individuals and their families, and they are the same issues that people have been telling us through the research for many decades. So transport and poor communication by health services, poor access to multiple health services, mental health issues, and one of the things that one of the pathways on the PAR tool is rongoā, or traditional. Well, actually, it's not traditional; it's Māori healing, so it includes contemporary and traditional Māori healing. So that was a good service to be able to offer. Next slide.
I just add into that. So a lot of people in New Zealand anyway think of rongoā as being rongoā rākau, which is herbal medicines, but actually a lot of the patients in this trial were more interested in some of the other, I guess, more holistic components of rongoā, like mirimiri, which is massage, whiti kōrero, which is having a kōrero around cultural support and advice, or having karakia, which is a Māori rare.
Thanks. Yep. Next, oh yeah, there you go. And I think it's unethical to offer cancer care navigation without clinical support, because whānau have massive unmet clinical needs, both in terms of their cancer and their other health needs. So I think the health service owes it to our whānau or our families to provide the best care, and that includes integrated whole system support. So Ash, our nurse, was really busy in this trial, and remember, these patients have been referred by their GPs or by other doctors, so if the health system had been doing its proper job, they wouldn't have any unmet health needs, because they've only just recently seen a doctor. But of course we know the health system's not working as it should, so there was a lot of stuff for Ash to do, and so some people required very minimum and some people required a lot of support. So next slide. Before I hand over to Amy for this, Ashley was supported by a clinical team, and that included a senior Māori GP and a senior Māori cancer doctor. But there wasn't a lot of demand for their time, but they were there in the background, so that's part of the holistic, high quality approach. And we did a survey.
We ended up developing our own survey because there didn't seem to be one when we scoped out that covered all the domains that we were trying to look at. So you can see that those are kind of listed there. We ended up with one that had 15 questions, and the response options were ranging from definitely yes to not at all. And we were looking at their whole cancer care journey. So it wasn't just asking how they found the WHIRI approach or the research. It was about all their cancer care. So we ended up phoning 30 participants. People really appreciated the free healthcare and understood the pressures that staff were under, and really enjoyed and appreciated all the support they got from Ash and Helena, our navigator, and our nurse. But one thing that we thought was a really positive response was that 100% of them said definitely yes or yes, that the healthcare team listened to their views and concerns, which is not always the case, as we know, for Indigenous populations. Sorry, skipping ahead. Don't do that, mouse. But yeah, so yeah, very positive response, and lots of whakaaro. We need to do a bit more analysis on some of the qualitative responses there, but the quantitative responses, yeah, might admit that their journey was looking very good. But I think, as Nina often points out, for Māori the bar is set pretty low, so they tend to rate their healthcare quite high, even if it's not good enough from our standard, I guess. I'll let you finish up, Nina.
Yeah, so we are still writing that study up, and we are starting Cancer WHIRI 2, which is going to be the whole one right to the end, and that's going to be in 2 locations, and we're going to develop an implementation toolkit and test that, and then at the same time we've just submitted a 5-year program grant to do the same kind of thing for breast cancer symptomatic detected breast cancer. So exciting times. And at the same time as we've been doing the research, we have been pushing nationally to get cancer care coordinators funded, and we have been successful with. Oh yes, thank you to our funders, the Health Research Council of New Zealand, and thank you to the team, especially a call out to Helena, our navigator, who had recurrence of her cancer during the project and decided to stay on and continue with the mahi as much as she could, and she's still part of our team. Oh yes, a bit of advertising. Please come to Aotearoa in 2026 for the World Indigenous Cancer Conference. Woo-hoo, it's going to be fun. Well, it's going to be in April. I think. Yes. Correct me. As we have been, I'm going to talk and try and share my slide at the same time. Is that going to be working? Oh, yes. So at the same time as we have been doing the research, we have been advocating for the establishment of cancer care coordinators nationally. And we have been successful because we had, in New Zealand, for a very brief amount of time, we had Te Aka Whāora, which is a Māori health agency, a national Māori health agency, which was amazing. So Te Aka Whāora funded 20 cancer care coordination services in collaboration with Hei Ahuru Mowai. And those services are running as we speak, and we're going to hear from Kirsty later. So, and as you know, I'm speaking for Robin, who is the National Cancer Care Coordinator nurse who's doing a fabulous job. And Robin and Hei Ahuru Mowai provide support to those 20 services, and a lot of kind of political support as well as hands-on support. And I think in Robin's first 2 weeks of the job, she travelled the whole country and met almost all of them. So it's pretty amazing, Robin, what you do if you watch this later when you come back. And I like to start off with a case study. So this is a classic story of a Māori man referred with cancer, and due to poor communication, poor engagement by the cancer services, lack of that ability to connect, Hone declined treatment. He happened to know in his local community who the cancer care provider was, coordinator was, and he walked in to the service and sat down and let them know that this was going on, and they worked with him to give him the information he needed, support him to treatment, and meet his health needs. Because if you have overwhelming needs, then it's really hard to kind of focus on something else. So they supported him, and he was able to access treatment as well as access other things that he needed to improve his health and well-being. So the team at Hei Ahuru Mowai are working with the providers to support this vision. And this is the lovely Robin, who's on the plane on the way to Fiji for a beautiful holiday. And she is a senior nurse practitioner. So whānau ora is the community. It's a community-based, holistic Māori wellbeing model of care. So it's very closely linked to whiri. And yes, so she's doing a great job. So the 20 services, which are spread from the top to the bottom of New Zealand, do everything that you imagine is required to support families who are going through a cancer diagnosis, including, you know, big things like accessing housing. And we have, in New Zealand, we have Te Aotearoa, which is the National Cancer Control Agency, so they've been crucial in this project as well. They all of the partners have a passion and a heart to serve their communities, and that's their number one requirement. You've got to have that ability to engage. That's the first step, and they've all got that in bucket loads. And of course, it's holistic. And they don't just support whānau to access high quality, timely cancer care, they support them to access preventative care as well. And they're developing relationships, so Hei Ahuri Mowai supporting them to develop relationships at the national level, and they're also developing really good connections at their local level. So it's a really well-connected network. Another case study of another Māori man who was diagnosed with cancer, and once again the cancer services were unable, they did not have the skills to engage with this man in an effective way. So he once again declined treatment for his lung cancer and was able to be connected into his local Māori Cancer Care Coordination Service, who worked through a whole lot of issues, complex issues, and found him good house, connected him with his family, and he's now in remission, and he goes around and works with the Cancer Society to provide that Māori voice, and speaks in Māori community events about cancer and what services are available and what supports are available. There is an evaluation, and there's some really fantastic feedback from whānau, as you would expect. And now I'm going to hand over to Kirsty from Potiri Charitable Trust, and you can see our map there, which is actually upside down. It's supposed to be the other way around, because that's the bottom one is the waka, and the top one is Te Ika a Maui, which is a fish. Anyway, I'm going to stop sharing, and kaya koe te rākau, Kirsty.
Kia ora, Nina.
I was supposed to introduce you, and I'm going to... How do? I have something to read here. I don't know how to get it. Oh yeah, so Kirsty is, while you're getting your slides up, Kirsty is the Chief Executive Officer of Potiri Trust, including Potiri Wellness Centre and Te Wairoho Cancer Care Coordination Service. And Potiri Wellness deliver a range of cancer supports, from prevention, support to diagnosis and advocacy, and for whānau in quite a large area. And so I'll hand over to you now, Kirsty.
Kia ora, thanks, Nina. Can you see my slides?
Right, beautiful.
Did I share that correctly? Beautiful.
Yeah.
Well, thank you for the opportunity to share a little bit about what we do. As Nina mentioned, we're one of 20 cancer care coordination hauora providers throughout the country, and so we're really blessed to have the support of Hei Ahuri Mowai, but also of each other. And so we work with 3 other cancer care coordination services in the Bay of Plenty in Aotearoa, and I think if Bubsy is there, we'll just mihi to her if she is there, because she's very much our tuakana in this space, because Aroha Mai have been delivering for a long time, and so we're really blessed to be able to learn from her and others. So this is part of our team, or those who happen to have been willing to be dragged in front of the camera one Friday when we pulled the camera out, and we're just going to explain a little bit about what we do. So we were established in 1986. We're established as one of the original Māori development organisations that was set up to support other emerging Māori hauora providers throughout the Bay of Plenty and Aotearoa region at that time. For the Cancer Care Coordination Service, it's Potiri based in Te Puke and also Kimi Hauora, who are also in the Bay of Plenty. So together we work quite closely. Kimi Hauora is in the top picture there, and this year or end of last year they won the Prime Minister Gold Science Award. So we're super chuffed. They'll be horrified that I put their photo up and told everybody because they're so humble. But actually what occurred is in the 70s they had a number of fires or aunties in their community who refused to accept that their family was cursed when a number of their family were passing away, and they didn't have any answer as to why. And so they started banging on doors of our universities, and they found a professor at Otago University, and they went on a journey in the 80s and were able to discover the CDH1 gene for stomach cancer, and they've been really active in that space ever since, supporting families right throughout the country who have that gene to make the right decision for them in terms of taking their stomach out, or if they choose not to, and if they do have cancer, they support them through that journey as well. So we have providers that work right throughout the Bay of Plenty, and then we also have our own work in Te Puke. And so in Te Puke, we work with about 6,000 whānau a year. We have a medical centre, and that's where our Cancer Care Coordination Centre spends some time inside our medical centre with our clinical team, working right alongside to support whānau and patients, but also equally important out in the community and in whānau homes and in our marae and at our kohanga and all of the different places where whānau are. That's where we need our Cancer Care Coordination services to be. They also have access to wraparound supports though, and so we have AUS Navigation services, we have disability services, we have a kaumata or an elderly wellness program that happens on our marae every week. We have nurse-led services that are mobile throughout the community. We have free whānau fitness programs. We have employment and education programs. We have mental health and addiction and counselling. We have whānau order supports, as Nina's described already. We provide some transport as well when that's a genuine need. We have healthy homes. We have Kai security and Kai sovereignty programs. We're part of the comprehensive primary care team innovation pilots at the moment. And so Te Wero Hau, our Cancer Care Coordination Service, is able to access all of those services seamlessly alongside making sure that whānau who have a cancer diagnosis are able to tap into the supports that they need on that journey, alongside being more proactive in the screening side too. So while we work with a number of whānau in our community to encourage them to be engaged in cancer screening, at the moment we're working with 71 whānau who have a cancer diagnosis, and 68% or the majority of those are Māori, but we also have and welcome Pacifica whānau, any other ethnicity. We have European, New Zealand European Pākehā whānau, and we have also a large Asian and Indian community in our Takapū as well. We have two staff members that are dedicated to our Cancer Care Coordination Service. So we have a lived experience navigator or kaiarahi, and her name is Whāio Auntie Dinky Portiki. And we also have a nurse practitioner, Sandy Smith, and so they work together at times and also work separately in terms of the different things that whānau are needing. We have something called a wayfinding process, so we don't wait inside our building for people to suddenly come and find us. Particularly, our navigator is active right across community, marae, making sure that families are fully aware of the service, connecting in early, are active with screening, as well as making sure that if they do have a cancer diagnosis, they know that there's support's available for them. We provide that support face-to-face, appointments, consults. We go alongside with them to appointments. We provide transport when that's an issue to specialist appointments. But we also equally visit whānau in their homes, spend time with them and their whānau as well. And we stay in regular contact by phone, by text. Whānau tell us whether they want that directly or whether they'd like that with a key whānau member that's one of their key supports on the journey. And so whānau really kind of tell us or dictate to us kind of how they want things to work for them. We also facilitate whānau hui, particularly when whānau have cancer, and the whole dynamics within their whānau has changed, and it can be a really difficult time. And so we're often asked to come in as a neutral person in to help kind of with the changing dynamics, but also help the whānau who has a cancer diagnosis to be able to have a voice that says things like, I am still very much alive, and so can we all focus on that rather than feeling like you all are expecting that I might pass away tomorrow. And so we're able to have support courageous conversations that sometimes need to happen in terms of how those with a diagnosis want their whānau to be supporting them in the mindset that they're wanting their whānau to have. We also facilitate hui with a range of cancer staff. So it could be the local cancer nurse specialist, it could be oncologists, surgeons, radiotherapy staff. We also go to advocate or just to listen and support, because sometimes it may make some sense, you know, inside a consultation, but at home, you know, it's hard to explain to family, or it's hard to remember all of the information that comes across, and so we can provide that extra support and help to remind or help to provide that next level of cancer health literacy along the journey. As I mentioned, we provide transport or we provide travel assistance if whānau are able to transport, but sometimes finances can be difficult. We also network with social service agencies, so we spend a lot of time with our local Ministry of Social Development in terms of accessing funds, and we also have a small fund that we can also utilise to help when finances within the family radically changes and there needs to be support and budgeting and other things that need to come into play. We also network with other cancer care coordinators to see what's happening within their areas and their communities, what's going well, and so we can share from each other. And we're also really blessed that He Ahuru Mōwai keeps us connected across the country, and so it's a great opportunity to stay abreast of whatever else everyone else is doing, alongside working with other local, regional and national cancer agencies like, for example, Breast Cancer Aotearoa and particularly the Tauranga Trust. And so for us, it's very much whānau that are driving the priorities, similar to how it happened with the whiri model, that whānau are driving the priorities for us in terms of our response within our cancer care coordination service. This is a photo of one of the whānau wearing really proudly one of the Cancer WHIRI shirts that was designed by the whānau and we printed for them and also for our team. And on the back, it also has the age to start self-checking, for lumps for breast cancer, the age to start mammograms and how regularly you should start. And so it's got some key information. And so our mission is to turn us all into walking billboards, but to create those opportunities to continue to normalise conversations about cancer screening, the importance of it, as well as also support for whānau who have a cancer diagnosis. As I mentioned, so we can attend appointments if the whānau would like us to. Because we have a nurse practitioner also, she helps to explain treatments, medications, and she can also prescribe. We spend a lot of time working directly with hospice and the doctors and nurses to try and provide a seamless service, so we're not relying on the whānau that we're working with to be the communication between us. As health providers, that actually we can also join up together to relieve that stress and to provide that korowai together. And we provide support also at the end of life stage and also beyond. This is a quote from one of the whānau that accesses our service. And actually, he's not based anywhere near us. So he lives about 6 or 7 hours drive away, but actually his whakapapa or his iwi is in Te Puke where we're based. And so the power of whakapapa and connections meant that him and his whānau follow us on our social media, on our Facebook or on our Instagram. And so when he was struggling in hospital in the final stages of his cancer journey, and he's just recently passed, that he called out to us. He is one of our colourful and complex whānau. He had strong gang affiliations and lots of facial tattoos that showed his affiliations, and he really felt that he was being discriminated against within the hospital, and he didn't feel like he was being heard. And so we were able to connect up, even though we weren't in the same community, provide local supports, but also provide some additional assistance for him in his final time. And the te reo part basically says thank you to our organisation, to Potiri and those that were involved in Potiri for coming to support me in this really difficult time. And although the mountain seems really, really big that's ahead of me, it was really helpful to be able to have that support. We're also excited because we have some new medications coming into Aotearoa, and so we're really keen to be a part of an equity-focused approach to that. We're really focused because whānau have told us really clearly as part of our co-designing process that they feel that the health system, sometimes they feel quite disengaged from and want to feel more engaged. Sometimes they feel disempowered in terms of how our health system can be really difficult to navigate, and they want to feel more empowered as part of the journey. At times feel that health services can be quite reactive, or we're funded to be reactive, but would like to see us be more proactive. So we're really excited to be able to work just as much in the screening space as we are with whānau who have cancer. Also that they wanted to make sure that they didn't feel like we were treating them, but actually how we continue to focus on strengths and flourishing, how to make sure ultimately that we have a continuous relationship with them and their whānau, not an intermittent one. And that fits really well with all of the research around the importance of continuity of care, but also culturally we are relationship-based. And so it made real sense there. And also how sometimes whānau feel that it's very transactional, accessing health services, and how they wanted us to focus on health outcomes. So we've taken on those challenges, and that provided some of the foundation for how our cancer care coordination service is evolving. We're really excited in the new medicine space for hauora providers like ourselves and the other cancer care coordination services to be able to partner, to be a part of the solution, because we have those continuous relationships. Those relationships are not cold and having to start from the beginning. They're already warm relationships, particularly with colourful and complex parts of our community, which is where hauora providers really shine. Others may find those parts of the community hard to reach, but actually many hauora providers, we whakapapa there, they are us, we are them, we're part of the communities that we're serving in. It also means that once a whānau has a cancer diagnosis, you're building on existing relationships. It feels less transactional and you can bring in holistic supports easier. It's not so overwhelming. We also have really good relationships in place with the Cancer Care Centre in the Bay of Plenty, and also the oncologists who've been really fantastic. So we're excited to be a part of the new medication supports, making sure that it's closer to home. Our nearest hospital, which I know in larger places will feel like a luxury, but our nearest hospital is about 45 minutes. The reality for us, though, is many whānau sometimes can't afford to travel there, don't have a car, don't have petrol, or don't have a legal car to drive, or can't drive anymore and don't have a family member that can take them. So it still can feel a really long way away, and then it can feel really sterile, really cold and too clinical. So we're excited about being able to provide a solution to have whānau-centred care closer to home. We've got a partnership with the Māori Pharmacists Association, so we're excited about that as well. We're really keen to implement the whiri model, so we're really excited to be able to connect in and be a part of that. We really feel that will also reduce the load on secondary services, and it provides an opportunity, workforce opportunities for us out in primary care and community care. And we're hoping that we get to also be a part of the new community infusion centres into the future as well. So for us, this is what hauora looks like for us in reality. So yes, we have consults inside our medical centre, but we also have opportunities to connect with our ngahere, to learn more about the healing properties of our ngahere. We also have opportunities to support wraparound supports for rangatahi who may be struggling when a grandparent or a parent has a cancer diagnosis and on that journey. So we have a number of rangatahi programs that kick in. We have virtual doctors and nurses appointments when they can't come in face to face. We have a range of
Absolutely wonderful. I can't believe how well-rounded and balanced your program is. It is so impressive. Questions from people who had the opportunity to enjoy these different presentations? Questions from anyone? And if you'll raise your hand, I might be able to see it on here. Okay, Sandra.
It's not a question. It was just to say, I think that was an incredibly, well, it's an awesome presentation, but actually what you put together is incredibly impressive, and yeah, real privilege to hear about it. So thank you very much. Unfortunately, I'm going to have to go, but anyway, I'm really pleased I got at least this part. So okay.
Thank you, Sandra. Thank you for joining us for this too. Really is a model program. This is quite wonderful. Comments, questions from any of the other participants? And I will ask the presenters if you could go ahead and send me your slides if it's okay for me to post them on the website. And if it's not, just let me know. Gail, you have a comment or a question?
Yeah, thanks, Linda. And apologies, everyone, because I'm now on my phone. My computer mic and sound has decided not to work. So I'm watching on my computer and listening on my phone. And anyway, so hopefully you can hear me okay. But I just want to say, Nina, to you and the team, what an awesome comprehensive program of patient navigation for Maori. I just think it's awesome. It's inspiring, and unfortunately, us, and we'll present our slides in a moment. In Australia, we're not at that comprehensive. We're at the very, very early stages of thinking about patient navigation, even though it's been something on our mind, for many, many years. But Linda, I guess this question is to you. I mean, obviously the presentation today shows comprehensive care from not only when someone receives a diagnosis, but is also talking about supporting family, cancer screening, access to medicines. How does this program go in compared to other programs? Is it quite similar to what's happening in the US, for example? I'm just trying to get some sort of a understanding of how this sort of comprehensive approach, fits in or aligns with similar programs, perhaps in the US or Canada.
We actually are seeing more and more of the navigation programs cover all the way through the full continuum of cancer care. When Harold Freeman started navigation in our country, it focused once people were diagnosed. And many of the programs that focus on nurse navigators start with diagnosis. With a lot of our community programs, we start with what we call outreach and education to the community and bringing people into screening. So we like to emphasize preventive programs, exercise programs, chemo prevention, and all of that, all the way through end of life. We also find that it's important when you're dealing with the full comprehensive continuum that you need to have your navigators have more than one. So even if your navigators are part-time, that they can share the responsibility and work with one another. Because and there's times like with when our program was earlier, we had a navigator who couldn't work with end of life, but it was very much for a cultural reason. And it's because in her tribal beliefs, if she dealt with someone who died, she had to really pay a lot of money and time to go through ceremony before she could help someone else. And so we learned that we had to have teams of navigators so that it would be a friendly handoff to someone else who really knew the patient and the family well on how to do things wholeheartedly. The other thing that's happening in the States, and I may address this with the IPEN early in 2025, is that we finally have reimbursement codes for part of the cancer continuum. And it was only approved, they started last January, but what happened with the approval is that people said we're missing the whole prevention and early detection part of the continuum. And we're trying to get what we call Medicare and Medicaid to include codes that include the earlier referral to screening, the time you spend getting people into screening. And the first part of the codes, we're only looking at supporting someone maybe 6 months after their cancer diagnosis. And as all of you know, our patients go through follow-up symptoms for years. We have people in our survivorship program that 20 years after, they still have side effects from either the cancer or the cancer treatment, or what we call late effects. Could be the heart conditions from adriamycin and some other chemo drugs. So there's a lot of different things that are happening in the States now too. And at some point early in 2025, I will share some of the things that are happening. Some of them are quite exciting, but I think looking at the full cancer continuum, that is where the field is going. Okay. So we're not just focused on one phase, but it's taken a long time to get there. Absolutely. Corey, you have your hand up. You're on mute.
Yeah, that was completely, can you hear me?
Yes.
Yeah, okay. That was so awesome and so inspiring. It just, wow, that was just incredible. I had a question about how is care provided to Indigenous people in New Zealand? Do they have, I mean, here in the States, we have the Indian Health Service, which is per capita funded less than prisoners that are people in jail. So it's very, very ill funded and kind of has its issues. But I was just wondering, what do they have in New Zealand for Indigenous people as far as providing health care?
I can answer that, Linda, if you like.
Sure.
So kia ora, Corey. That's a very pertinent question. We have free secondary and tertiary healthcare, so it doesn't cost anything to get cancer investigation and treatment. Some people do choose to go private when they have to wait for too long. Not many people have private health insurance over here. Primary care, so family doctors, which is what most people use, is partially funded by the government, and there are some family doctors that are free. Most, in areas where there are high Māori populations, so some of them you have to pay a little bit, so maybe like $17. And in areas where there are lots of rich people, it might be up to like $80. But it's getting increasingly harder to access a family doctor because they're closing their books. They haven't got enough of them really. So a lot of Māori people use the emergency departments at hospitals and emergency primary care, which can cost about $80. So we have a partially private and partially publicly funded system. But there are quite a few community-based Māori services which provide a whole range of services, and Kirsty's Potiri Trust is a really good example of one of those. And
thank you, Nina, very much. That's very helpful. in Corey, what you hear is they do actually both Australia and New Zealand have a much stronger support for the healthcare system than what we get through Indian Health Service. It's really abysmal in comparison. And Nina, you had your hand up also.
I made some notes. We are, gosh, what was I going to say? Oh yeah, so Aotearoa always working at the national level to get so that each community provider doesn't have to reinvent the wheel. I mean, ideally we would have done this first, but we had the opportunity to get the funding out, so we're doing it a bit backwards. So we're developing up training modules for navigators and nurses, looking at trying to develop up a national needs assessment with screening questions and follow-up protocols that's electronic, that navigators and nurses can then use and can be localised to their own services. And then we're also, Kirsty talked about the new medicine, so we're getting some funding for some new chemotherapy drugs and other drugs, and we are hoping to develop services so that Māori can actually receive chemotherapy within community providers. So mostly, if you want chemotherapy in New Zealand, you pretty much need to go to a secondary or a tertiary hospital, so one of the big hospitals. And many people who live remote, rural, do not get chemotherapy because they just can't get to the big hospitals because of transport and accommodation issues. So we're hoping that we can set up, chemo chairs in Kirsty's service, and that we can get hundreds of these chemo chairs out into the community, and people may have to go to the main hospital for the first couple of sessions of chemo, and then they'll receive the rest of their care out in the community with their Māori support team wrapped around them so beautifully. So the other one we're trying to get a national approach on is entry into the cancer care navigator pathway at referral, pre-diagnosis ideally. So that's, we've got a lot of wishes on our wish list.
Nothing wrong with that. Gail, you have your hand up.
Yeah, just a question for you, Nina, and the team. And so the background of the patient navigators and the training, and do they need to have clinical expertise? Because I know there's a lot of variation across the world, in people with navigation. So really keen to get your initial thoughts about that. And then just the second thing is, and maybe this is a discussion for another time though, Nina and Linda, because Linda, I know you've been training patient navigators for, I don't know, a very long time and developing modules. And I'm wondering if through, this IPIN, if there's an opportunity for us to look at what we're doing in each country, because, even though it's very, very new for us in Australia, we've been developing some training modules, and whether we can come together with an international set of sort of some training aspects that it may or may not be possible, but I think it's worthwhile having a discussion. Oh, look, I'm the ideas person.
Let's do a research project, guys. Meet in Hawaii and discuss it, shall we? It seems to be the closest place, but so we have been talking about that. Kanita has started some discussions on getting core competencies for navigators. And, off the top of my head, when we employed our first navigators, the main competency was the ability to engage. They have to be Māori. Actually, no, I think we had one non-Māori navigator in the start, Amy? But she had that ability to engage. But yeah, so just a big heart. And if you don't have a big heart, then go and apply for another job somewhere else.
Be culturally connected, obviously.
Yeah, culturally connected.
Being Māori, I think all our navigators have been Māori.
Okay, yeah.
Yeah.
I completely agree. I think in some of the bigger cities, it may not necessarily be as important, but in smaller towns like us, you have to have someone who's known and trusted. You have to have someone who actually knows who the local iwi, hapu, marae are, who has those networks. Otherwise, you have to spend a lot of time developing those, whereas the doors will fly open a lot easier when your navigators are known. And that's how it works for us because we're in a smaller community. Maybe in bigger cities, it may not be quite as necessary, but yeah, for us, that's been really important.
And you know, you can, it does, we found it does take a lot of, some things took a lot of training, like the kind of clinically kind of things, like the smoking cessation. We had to redo that, like, felt like a million times till we got it right, but eventually we got it right. You know, non-medical people can take blood pressures, and you'll get a lot of resistance. Non-medical people can take bloods, you know, that you do have to go through some training. Yeah, so being medical, I think, is actually not a good thing for a navigator because, for example, when we did our randomised trial in paediatrics with the health needs assessment, we did that with 1,000 whānau. Like the navigators told us, you know, oh yeah, we've got a lovely Māori nurse who comes in her nurse's outfit and will ask the patient and the families, oh, are you all ready to go home? You've got everything in place? And the families, yes, nurse, all good. And she is a nurse, but she still had that really strong ability to connect. And then the navigator comes in and asks the same question and they break down in tears and say, no, everything's turned to shit and our car's broken down and we've got no food and the electricity's been turned off. So I think not being part of the system is a massive bonus. Sorry, that was a long answer.
Yeah,
well,
but yeah,
I think
all kinds of backgrounds as well, like from teaching to psychology, just non-health. So yeah, being able to connect with people is really the core of it.
And Gail, I don't want your idea to drop. I do think we should probably have a session talking about what we're doing for training for our navigators. And maybe we'll do that early in 2025 also, because it'll give people other ideas and also how the hours change depending on what type of navigation. So like when we started in 94, we had less, I think we had 35 hours of training and we realized that was way too low. Then it was 125 hours. When we do the full cancer continuum, it's closer to 300 hours of training, not all at once time. You start off and then you have refresher courses and then you have additional courses. As they start working with cancer other than the screenable breast, cervix, colon, lung, prostate, and skin, they start dealing with lymphomas and other things. It takes more training. And, you know, stomach cancer, things that are very common in a lot of our indigenous communities that navigators have to be able to talk about it, you know, with them too. Jay, you have your hand up.
Two questions for Nina and Kirsty. Do you have problems getting identified Maori people into positions? Because I think that's one of the big problems in Australia is I have a lot of my Indigenous patients saying to me, we need more Indigenous people in these roles, but it's really hard to find the workforce to come into those roles. And then my second question is, do you have patient travel? So where I live up in far north Queensland, right at the top, there's lots of remote Aboriginal communities and there's a little primary healthcare centre in those communities, but they come to Cairns for their cancer treatment and patient travel is funded and they are paid accommodation and flights and everything is paid for their duration of their cancer treatment. Is that offered in New Zealand?
They can claim it back through National Travel Assistance, but normally they have to pay up front. Yeah.
And
the rules are really tight and bad.
Yeah.
And we have so many letters to the government.
Yeah, but
it's not very
the government is
accessible.
looking at reform in that space as well. So
Yeah.
Sorry, Kirsty.
No, that's okay. Just in response to workforce, I think we are doing really well here in Aotearoa because workforce has been invested in for the last 20 years. So the Ministry of Health established 4 workforce centres originally in mental health, and that actually was able to be broadened across Māori health. That's been in place for quite some time, and a pipeline approach, right from kind of trying to make sure that high schools and early stages of high schools are understanding and having exposure to, Māori health clinicians and the importance of why you take certain subjects and why you need to take science all the way through. And then there's a number of schemes within universities that's trying to support and make sure that Māori are able to still continue to thrive as Māori in those tertiary education environments and be able to gain the clinical qualifications they need. And then there's career pathways, once they're in health. So we still have lots of areas that are underrepresented. For us personally, we actually, at the moment, and have for a while, found it easy as long as we have the resources, because we are similar to one of the whāia who talked before, where we don't have the same equitable funding that mainstream organisations have. So, but if you do have the funding, then hauora providers actually do really well at recruiting out of our hospital-based services that are not always the nicest, places to work, particularly for Māori. And so it's not difficult for us to recruit over to the dark side of hauora land, but it's primarily just whether we've got the funds to be able to compete with salaries. That is one of our biggest issues.
Great. Any other questions or comments for our New Zealand team? Our dynamic Maori program. Woohoo! Okay, Gail, let's turn it over to Australia Aboriginal Navigation. And who do you want to present first, please? And you're still on mute.
Can you hear me now?
Yes.
Okay,
Good.
great. I'm still going between computer and phone. Crazy. So Lara from our team is going to share the slides, and then I will speak to the first 2 slides, and then I'm going to hand it over to Shannon and Jay, and then I'll finish up with a couple of slides. So it's a real team effort here from Australia as well. And presenter view, great. And so our patient navigation program here in Australia, in Brisbane, in our specific project is called First Nations Cancer Clinical Nurse Consultants. They're pretty much patient navigators, but we couldn't call them patient navigation or navigators because they're based within the Queensland Hospital and Health System, and it's patient navigation is used in a different program. So we were unable to use patient navigation. So our program is called the First Nations Cancer Clinical Nurse Consultants. And as I said, Shannon and Jay will do the presentation today, but I'll just speak to the first slide. Before we get to this next slide, I also have to thank Lara. Lara is our project manager who provides enormous support to our 3 navigators or First Nations Cancer Nurse Consultants, and does an amazing job in coordinating, collecting the data and doing all of the logistics, including practical support. And Jay and Shannon are on the ground in the hospitals. Let's go to the next slide. So, and apologies because I just threw this one together for the background, but I'm sure we could work through it. So quite different to Aotearoa, New Zealand, and to many other countries who are doing patient navigation. In Australia, we're in the very, very early stages. And whilst Linda, when I first started looking at patient navigation, I think this is in the days of the Walking Forward project and navigation that you led, the various iterations of that. I looked at that, reviewed the program, and thought, this is something which we can actually do here in Australia. Now, that was 15 or 16 years ago, and we're still trying to get more comprehensive patient navigation happening here in Australia. But there's a little bit of movement now. So we actually did some time ago a pilot project to actually investigate whether having an Indigenous patient navigator in a tertiary care hospital system worked, and what were some lessons learned from that. So pretty much we found pretty good engagement from patients to our navigator. However, our navigator wasn't embedded in the hospital system. They were in the research setting. So they came in and out of the cancer care and hospital system. And so that caused a whole range of issues around patient referrals, for example. They weren't able to do patient referrals because they weren't a part of the Queensland Health Cancer System. The cancer care coordinators and other clinical staff also didn't engage with our navigators because they saw them as someone external who was doing a research project rather than trying to help with the coordination and navigation of patient care. So the overarching main outcome from that was that if we were to have patient navigators in cancer care supporting our Aboriginal and Torres Strait Islander patients, they pretty much have to be embedded within the health system. And so that was our recommendation, and then we've been trying to get some funding for navigation ever since then. Last year, we had a whole group of non-Aboriginal and Torres Strait Islander people and nurses primarily with Cancer Australia who did a systematic review on patient navigation across the cancer continuum. They looked at how navigation works and what should happen. And so in that review, they also mentioned that patient navigation could work, but for Indigenous navigators, there might be some tension between Indigenous and non-Indigenous service providers around the role and responsibilities and around the structure and how patient navigation is delivered. They also mentioned in that systematic review that Indigenous navigators could actually offer better culturally tailored support, could provide information that is in lay terms. They have that cultural trust, so that patient-provider trust is already existing, which we spoke about briefly. And then they made a recommendation that research is really needed to understand the cultural factors for facing Indigenous peoples, Aboriginal and Torres Strait Islander people here, so that then they can develop patient navigation. So that review, I've critically appraised it, even as recent as last week at our National Clinical Oncology Society of Australia. I said there were obviously limitations in this because we actually know that, and we have a lot of information, and some of it we'll present today, qualitative information about, we know what the cultural factors are and the needs and the challenges that our Aboriginal and Torres Strait Islander people face in hospital. We've been reporting this time and time again over an extended period of time. It's really time for action. And what this group did do is exclude and not include Aboriginal and Torres Strait Islander people in the conversation or in the recommendations and the narrative around patient navigation. And so that's something that is also missing. So Lara, if you could just click the next bit. Thank you. And so last year, the Australian government has provided substantial funding into cancer. We now have Australia's first Australian cancer plan. We now have our first Aboriginal and Torres Strait Islander cancer plan. And then, so there's millions, hundreds of millions of dollars being put into cancer care in Australia. There were about, I think it was 200,000 or something like this is put into developing an Australia cancer nursing and navigation program. So this is all being mapped out now There's organisations which have been engaged to develop this navigation program for all Australians. What is critical is that they engage with Aboriginal and Torres Strait Islander people, and that our voices are heard and privileged in developing such program, rather than just going with the same rhetoric and lack of understanding which they had previously. So navigation is very new. We did a feasibility study. There's a few other little pockets of work that are happening around, mainly from a research perspective rather than a health service perspective. So anyway, we then received some funding, and then now we have this project. And this is where we're actually piloting First Nations cancer nurse consultants, patient navigators, across 3 large hospitals in Queensland, tertiary care settings, to provide culturally responsive, supportive care to First Nations cancer patients and their families. And this project is a part of a much larger project that we're doing here in Queensland. So on that note, I'm going to pass it over to our 2 First Nations cancer nurse consultants. Thanks, Lara. Thanks, Jay and Shannon.
Thanks, Gail. Sorry, First Nations people's experience of cancer care. So there's the absence of culturally appropriate support services. There's a lack of having that connection when they come into a hospital of someone that understands their cultural needs and to help them communicate. Feeling isolated and experiencing a loss of identity within the system. So going away and being treated, that's the biggest thing. Away from home, family and country. Uncertainty and lack of support. When I walk into a hospital today, I'm very wary of who I can trust. And that is a huge one that I find with our patients coming from our remote areas of Queensland. There's logistical issues and anxiety around transportation and accommodation. And again, coming up from the anywhere 50 kilometres outside of our hospital radius, the patients are approved for travel subsidy and accommodation, but they still face a large out-of-pocket expense with the accommodation, and it's roughly about $70 a night when they come up to the hospital, and sometimes they're here for weeks while they're having treatment. There's a lack of own resources, no money for travel or food, lack of understanding or respect shown by healthcare providers, individual, family and community priorities, family worries whilst in hospital, bringing the worries from home. When you support an Aboriginal person, you need to consider the family. Understanding of cancer, cancer treatment and health literacy. Thanks, Lara. The First Nations clinical nurse consultants were employed in 3 diverse Queensland cancer services to provide culturally responsive, supportive care to First Nations cancer patients and their families. Employed for a minimum of 12 months at a 0.8 FTE. The role involved data collection using patient-reported measures and clinical data to provide supporting evidence for ongoing funding. So these are for our 3 hospital sites. So these are posters that Lara had organised that we could put up around our waiting rooms, all over our oncology departments throughout the hospital, and radiation oncology. As a big barrier for us was our First Nations patients that were coming through that were being missed and weren't being asked the questions. By putting these posters up, hopefully that they'd recognise our face and comfortably approach us. Embedded in the cancer care service within the hospital, the First Nations we addressed the site-specific patient family need, We deliver optimal cancer care according to the tumour-specific and Aboriginal and Torres Strait Islander optimal care pathways. We support the service to increase cultural competence. So this is the hospital where I am. So it's Metro South. So it's the largest hospital in Queensland, as I said. It's a trauma hospital, and we service, I think it's about 6 hospitals on the south side of Brisbane, and 2 of those which have only just opened are small satellite hospitals which have attached to them a day oncology unit where patients are able to attend these small satellite hospitals to have chemotherapy instead of having to travel all the way into us here at the PA where we sit close to the city. So it's in a catchment of 1.6 million people with 1,038 beds and 5,800 full-time equivalent staff. I commenced this role in January of this year, and in the cancer care service, I sit in the executive suites with all the directors and all the other clinical nurse consultants for their cancer field. They've been extremely supportive of my role, and they've basically told me to do what I want with it and what is going to work for my First Nations patients. I identify my patients through an appointment list and in waiting rooms. I introduce myself and my mob. I talk about my role as a cancer services clinician for mob and how I can support them. I then invite them to talk about their cancer diagnosis, invite their support person to talk about how it has affected them. After some yarning, I will talk about our research role, provide them with a study brochure and ask if they would be interested in taking part in this study. I've found that most of my patients have said yes to taking part in the study. There's only a small amount that haven't, but I still obviously work with those patients, even though a large part of this role is for collecting that research to fund these positions. But it's very rare that a patient will decline taking part in the research study, which is great. And Jay, you're next.
I'm just telling my workmates to be quiet. Yeah, so this is me. I am up the top in Cairns, and the top of Cairns, we service the Cairns and hinterland as well as the Torres Strait and all the islands. So there's a lot of remote Aboriginal communities that were originally missions, and a lot of people live in these communities. Some of them have never come out of community before, and so when they come down to Cairns, it can be quite a shock to come down here. When my service sends out a weekly Aboriginal and Torres Strait Islander list of patients that are going to be coming into the centre every week. That list can be about up to 100 people, of new people coming in each week that are Aboriginal and Torres Strait Islander. I have a Indigenous liaison officer that I work with as well, and we try to engage with as many people as we can. Obviously, that's a lot of people coming in every week, and we're only 2 people. But I try to, especially if someone hasn't been attending appointments before, we'll give them a call just to give them that, hey, how you going? This is me. I'm going to be here to meet you. And one of us tries to go to their first consult when they're with the doctor, to just be in that first meeting with them to try and help with the language barrier and ask any questions. And I find that that's helping with getting more people coming to treatment. Yep, next slide. So yeah, challenges with people that we've found is there's a lot of people that don't attend. There's not a lot of communication between family members. I'm having a lot lately of, there's a lot of religious beliefs and people not wanting to come for Western medicine, and they just wanted to do traditional healing. So they're refusing any kind of treatment at the moment. There's a bit of miscommunication and understanding what the diagnosis means. Even when something's being told as this is non-curable, I've had to explain it multiple times to patients what curable and non-curable will mean. Yeah, there's a lot of the transport and accommodation issues. Even though we have the patient subsidy scheme, they're only allowed to have one escort to come with them from community, and that only covers a certain amount. And then there is usually a bit of a gap fee, which people can't afford. Yeah, lack of trust in the doctors and the medical staff, and a lot of issues with identification. If they haven't come out of community before, some of them don't have any kind of identification, which makes it a bit of a struggle as well. Next slide. Shannon, you want to take this one?
So how we have, we've been looking at the appointment attendance with the did not attend. So when I first came into this role, I was handed a patient file to say that the GP had phoned and made multiple complaints to the hospital about this patient being discharged to the discharged from the service. Reason being he had multiple fail to attends. So I actually, through contacting this patient, firstly with a text message, when he hadn't answered his call, I texted him, and then I continued to call him until he finally answered, and just had a yarn about what the issues were as to why he didn't come in. And transport was a huge thing for him. He was a stay-at-home dad, so picking up his daughter from school was more of a priority than the times that these appointments were being made. So rather than him communicate that with the hospital, although he said that he had on multiple occasions with the doctors, it was never handed over. So these are the only reasons why he failed to come in. So once I established a relationship with him, I would just call him weekly for a yarn and, to make sure he was coming in. I also engaged him in some community support services to help him with that transport into the hospital. I also asked for permission for a next of kin's details, that if by chance I couldn't contact him, I could also contact his next of kin, who happened to be his partner, the mother of his child. So the day that he came into his appointment, I met with him and his partner, again, introduced myself and my role, and asked if, there was anything else that I could do to support them in him continuing his treatment. Unfortunately for him, the type of treatment that he was needing to continue he would require a stem cell transplant, and for him, he didn't want to be in the hospital for that long, in which he needed to be here and as an inpatient. So both him, I sat in on the consultation with the doctor, and we had many consultations following up, and unfortunately he chose not to go through with treatment, and took the palliative care route, and to which I've supported him through that palliation period. He still is with us. But these are just ways that we've been trying to support our mob into, and it's not just one. This happens with probably 90% of my patients, that transport is the biggest issue. Transport, accommodation, and the financial costs of it all. Not to mention coming to a large tertiary hospital, that is very intimidating also.
Mm-hmm.
Thanks, Lara. Do you want me to do this, Jack?
Yeah, you talk. You're going well.
Okay. Other ways has been the improving communication and reconnection with family members. So as I spoke to on the previous slide, that is consent to talk with the family. Hold family meetings is a big part of what I have introduced here at the PA with my patients, as there is a lot of miscommunication I actually I've missed the family meeting for today that I had organised for all of a patient of mine, his palliative. Again, I heard from one of his family members, his enduring power of attorney, that his last appointment that he had attended, the doctor said basically, and this is secondhand information, the chemo's not working, so we've got to put you on, the oral chemo's not working, so we've got to give you an IV chemo. And your cancer's gotten worse, and sent him on his way. So the family member phoned me, which was his niece, really upset. And she said, what's going on with these doctors? And I said, look, let me look into it. I'm on leave at the moment, but when I come back to work on Monday, I'll definitely, it's the first thing I'll do. So I organised a family meeting. They did not want that doctor present, and they had requested to see another doctor. Unfortunately, he was the consultant, so it was really quite difficult. But instead of having a doctor present, I had the nursing practitioner for that tumour stream attend and do all the talking, and I was just there as support for the family. Again, that ended with, once all the information was presented, the patient decided against chemo and decided to take the palliation route, as he felt that going with the chemo, he would not have any quality of life. So I have multiple family meetings. Again, he's an inpatient at the moment. I speak with his family every day. I call them every day. And again, I've had to organise another family meeting just through lack of communication from the doctors. He's confused himself, but they seem to be giving him all the information that he can't pass on to the family. So again, that's where I step in, and I do try to be there for ward rounds so I can listen to what the doctors have to say and then relay that information back to the family. But for big, huge family decision making, I really try to get all the healthcare team together, that all of their questions can be answered and they can make an informed decision from that. Thank you.
Is this me now? Must be
Yes.
me. Cultural sensitivity and understanding of men's and women's business. I think CANS is not too bad because we see a high proportion of Aboriginal and Torres Strait Islander people coming through our hospital. And if there's any issues, you can just relay it back to staff, and they're always like, oh, so sorry, didn't understand that. I had a lady the other day that was in a 4-bay room, and they were doing a bone marrow test on her, and there was 3 other gentlemen in there. One of them was an Indigenous fellow, and I was like, this lady needs to be moved into a room with another female. And the staff were just like, oh, so sorry, that's just the only bed available. I'm like, I understand that, but for men's and women's business. And it was easily sorted, so there was no issues there. But I'm not sure what it's like in Brisbane, if there's a bit more discrimination. And
yeah, there's a huge lack of cultural awareness, and the PA are very keen to change that. But yeah, there's multiple occasions that I've also attended a bed space, and same thing, female elder in a room with all males, and one of those males, an elder also, with her curtains wide open while they're popping her on a pan. And you know, that in itself is just wrong, whether you're First Nations or non-First Nations. But having to have those conversations is really important, as I've had the families feedback to me that when they've brought it up with staff, they've been like, well, you're in a public hospital, you get what you're given. However, if, you know, these were Muslim women, it wouldn't even be questioned about them being in an all-female room. So I think that the PA are working on increasing their cultural training with staff, but it's still at early stages. Thanks, Lara.
Next slide, Lara. Oh, I'll do this one. I'm actually going to go attend an appointment at 1 o'clock today with a patient. So I've got a patient coming in with a new diagnosis today, and I gave her a call and just said, hey, this is who I am. I will meet you at your appointment, and go into her consult today. Yeah, and it's just really important to help with that language understanding. I'm not sure if I have an example there, Lara. I thought I did. Oh, there's something else. So this is before I had a patient. The social worker had come to ask about applying for terminal disability pension through Centrelink, and the patient didn't understand what non-curable meant, and we had to really break it down and have multiple discussions with her that non-curable meant that this cancer would eventually take your life, and it was a bit of a hard situation to be put in. She I had to actually tell her a couple of times and explain it in a way that was easy to understand. But there seems to be a few like that where we'll go into consults, and I had an elderly lady from the outer Torres Strait Islands that had a breast cancer that was from hormones, and they asked her whether she'd gone through menopause, and she didn't understand what the word menopause meant, and we had to just say it in a more simple term. So just makes you think, if these patients are going into consults without family members or someone that helps them explain simple words, like they're really not getting the understanding that they need. And just having us there is really making a difference. Shannon?
I discussed this in a slide just before, so we can move on from here. Thanks.
Yeah, we've talked about the accommodation issues and how, especially in Cairns, there's a lack of accommodation as well, because we have so many patients travelling from out of service. Some of these communities are 6, 8, 10-hour drive away, and all they're coming on little tiny planes. And there's only a certain amount of accommodations that patient subsidies that will accept patients from the patient subsidy. So a lot of them are full, and then there's rival clans staying at the same accommodation. So then this causes problems with drinking. So a lot of these people are coming from dry communities where alcohol is banned, and then they come to Cairns and they'll be drinking and fighting between those clans. So then they'll get kicked out of certain accommodations. So it's a bit of an issue trying to keep people in a safe accommodation, and they all want to have their family members with them as well. But obviously, yeah, it's only a certain amount of people that are covered by the patient subsidy. Otherwise, there's a big out-of-pocket fee. Shannon,
yeah, we are the same here at the PA. Our local accommodation, which is across the road from the hospital, have recently started giving away a lot of their rooms to DV victims. Apparently they're getting more money for it, but also it's rough accommodation. There was recently a murder at this accommodation. So you've got these families that are here having treatment, and they're having to deal with police there with murders, and anyhow, yeah, but we
substandard accommodation.
Yeah. So we again struggle with accommodation and the out-of-pocket expense. I get patients that come down to me from Jay's Hospital and Far North Queensland and the Torres Strait Islands also. So they can be here for up to 3 to 5 months, sometimes longer. And when you think about that $70 out-of-pocket expense per night, that all adds up. And a lot of this population are unemployed due to the lack of work up in those regions. So on numerous occasions, I've had to reach out to the directors of the PA hospital to have the out-of-pocket, to put my case forward as to why these out-of-pocket expenses need to be paid for by the hospital. And this again is one of the steps that the PA is taking to really bridge that discrimination gap. And they have approved upon case by case basis the out-of-pocket expenses for our First Nations patients. So, you know, that's a huge strain on families and patients when they are dealing with a cancer diagnosis, to have to think about that financial expense. And not only that, they're also got that expense for their living at home. So it's been really great that the PA have taken on this, and they have come through on numerous occasions to pay those. I also access cancer funds here on the ward, on the unit, and these are just a food vouchers for the local supermarket, so they're able to purchase food while they're down here. And I also access the Cancer Council's food and fuel vouchers for them also. Thank you. Okay, so patients getting lost in the system. We get in contact a week prior and try to arrange what supports are needed to get them to the appointment. One of the barriers is inmates that get released that are having treatment throughout their detainment and then being released prior to finishing their treatment. They're a big fall through the system. So for my patients, I get email addresses from them, and I also ask them where they plan on residing once released. Will they be going back to a family member or whatever? And 9 times out of 10, it's always a family member. So I also ask them for that family member's details also, because we never given a release date. It just, and nor are they, it just literally happens. And we also make sure that the next of kin details are up to date. Jay.
Sorry, I just had to mute because the doctor came in talking. Yeah, so just lack of trust in the medical system. As I said, like a lot of these people are from very remote communities. Sometimes it can be their first time into a tertiary centre. So just trying to ring them, make sure that they're aware of who you are. If you can't contact them, I've been contacting the primary healthcare centres in their local community to be like, hey, this is who I am. Can you please pass on my details? Let them know they can contact me. I have a mobile for work that people can text me on, and I'll get back to them if I'm not around when they've contacted me. Yeah, and we're just or meeting them in their consults and supporting of bush medicine, saying, you know, if you're going to take some kind of bush medicine, bring it along so that we can just link you up with pharmacy so we can discuss to make sure that there's no interactions. And yeah, Shannon, anything else?
Yeah, and I attend not all, but mostly all of the medical appointments with my patients, and sitting down. I mean, this is a barrier that we do face. There's no room in the hospital to have those private conversations. So, you know, I really try to be discreet as possible, but we sit down prior to the appointment and have a yarn. And during this time, we discuss what questions they might have for the doctor. I get them to write their questions down, or even prior with a phone call, I say, write down your questions that you want to ask the doctor so there's nothing you forget. And also orientating them to the hospital relieves some of their stress. As I said, the PA is a large hospital, so it is intimidating. You do get lost. So that's also a huge factor. And also, as Jay said about the supporting of bush medicine, I have another palliative patient. All my patients seem to be palliative, but they're not. She, again, hers is very advanced cancer, newly diagnosed, and she's the same. She wants to go back out to country and live what time she's got left as is, without any intervention. And while she was here in hospital, this was when she was weighing up the decision as to whether or not to do chemo. She discussed the bush medicine, and I happened to be there at the time, and the doctors were really trying to push her away from this. And so afterwards, I had to have a conversation with that doctor and explain why bush medicine is so important, especially to a person going through this and newly diagnosed, and the fact that she hadn't decided on her treatment. And at that stage, she was weighing up more just the radiation than the chemo. So, yeah, you find that the doctors really try to push them in the opposite direction away from the bush medicine. Next. Lara, thanks. I don't think, Jay, you would have too much issues with this, but here, the PA, there's some huge issues with the identification system. So the question isn't being asked to every patient that comes through the door. That should start with admin as to whether the patients identify as Aboriginal and or Torres Strait Islander. I've sat in on the Making Tracks committee here at the PA, and this discussion comes up a lot because I bring it up all the time, and how we can do things better here at the PA. So for me and for Jay, we wear shirts in a First Nations print that we can be identified. Also, with the admin staff, there is a cultural capabilities officer here that can give them that training, as it's come out that the admin staff aren't comfortable with asking the question. They feel like it's offensive, or the fact that someone may look Aboriginal and or Torres Strait Islander, but they've still got to ask the question, because as we keep trying to educate them, you can't just assume. One can look at me and be like, she's white, she's not, and just assume that I'm not. So yeah, there's a lot of assuming that happens, and I come across patient after patient where it's not documented on their paperwork that they are. And, you know, these patients are missing out on the support, a lot more support that they could be getting if the question which is being asked at the beginning. And I also think that nursing staff should also be asking the question, not just assume that it's all being done by the admin. Thanks, Lara.
So key learnings that we've learned so far through this research role. So I only started my role in May. So the data collection is quite time consuming and asking all the questions, and it's not just you go and meet your patient and you do your research enrollment. There's a lot of support that the patients require beyond just the questions and all the referrals that we'll send on from there. But it's quite important to get those questions so that you know where you need to send your referrals to. And because of that, because it's a bit time consuming and demanding, Shannon and I have both said that we are a bit of workaholics, and we take our work home from us. We take our work phones home and we answer emails on days off, and got to set those boundaries sometimes, but it's hard. And but yeah, we've found that building that rapport and trust, and it's helping getting those patients to come to treatment. I've found that I've built rapport with people just from gently harassing. Gently, I say gently. Yeah, knowing that they know that I'm here, they'll come along, and it's helped them come to treatment. So that's really nice to see. Is there one more slide, or is that done? Conclusion. This is my my story. Yeah, I had a 44-year-old breast patient from Yarrabah that wasn't engaging in coming to services and treatment anymore, and I gently harassed her a few times on my mobile phone and texted her and rang her and got her to come in. I've met her in a couple of appointments, and now she's started attending treatment. Unfortunately, her cancer has metastasized because she didn't complete her proper chemotherapy, but she's now on oral therapy. And we're just trying to re-engage with her primary healthcare centre to see if she can get services a bit closer to home, so she doesn't have to come in every day. Shannon?
So I had an uncle that was transferred to the PA. He was coming down from Townsville Hospital. He'd been lost. He had had a previous cancer diagnosis and completed all of his treatment, bar one radiation treatment. But he had been lost to follow up due to homelessness. He presented to the Townsville Hospital with a sore throat. He was a head and neck cancer, to which they found that he had cancer reoccurrence. Prior to him coming down, I'd had many conversations with the Indigenous liaison officers up at the hospital to say, heads up. He's very non-compliant in staying in hospital. We've had to send our ILOs out to go out and find him. You know, he's very known to go walkabout. So as soon as he was admitted, knowing that information, I was here waiting for him as QAS brought him in. He had no clothing, no toiletries. All he had was the clothes he was in that looked quite dirty too, and his phone. I was able to have clothes supplied to him from the PA Foundation here, and access Cancer Council vouchers from Cancer Services here. And I actually took him over to the shops myself, and we went and collected toiletries together, some snack food, you know, some comforts for him, and some phone credit. During this time, after all the initial investigations that he had done here, the PA were wanting to send him back up to Townsville to await his surgery that was going to be 10 days. Townsville Hospital refused to take him back, knowing that if they took him back, they would lose him and it would fall back on them. So the PA were then wanting to put him into the accommodation across the road. Through numerous conversations I'd had with Uncle, he had talked about his substance abuse with alcohol, and the fact that he would like to go to Musgrave Park to see if any of his friends are there. So Musgrave Park's a large park here in Brisbane where a lot of our First Nations meet, and a lot of drinking and homelessness there. So with that information, I said this isn't suitable for him, and he actually even admitted to me, if I go to accommodation, I'm going to drink. So he hadn't had a drink for the 2 weeks that he was down here. And the PA, I spoke to multiple directors of different departments, and we were able to pop him over to a private hospital as an overflow from the PA hospital. They pay for the extra beds there. And he was able to stay there up until his surgery. But part of that, I was also needing to go over to that hospital that's not affiliated with us to do education with the staff there, as they were failing to give him his pain medications. I'd be again getting phone calls at 8 o'clock, 9 o'clock at night from him crying, saying how much pain he was in. And so then I would phone that. And anyway, so lots of education done there over the 10 days. And I would go over every afternoon and take him off the ward to sit outside, where he could get back to nature, and we'd have a yarn. So, and this is a patient that also came down with severe hearing impairment that you would have to scream into one of his ears. I also had to advocate for the ear, nose and throat to their doctors to get audiology to see him, to have him tested, to which he was tested and had hearing loss. So we fitted him with some headphones and a speaker that people talk into until his hearing aids come in. But again, he's had his surgery. They sent him back maybe a month post because he did have complications, and he was literally back up at Townsville for 2 days, and they had to send him back again. So we've got him back again, and he relies heavily on me. I get multiple phone calls a day from him to go down to the ward to keep him company, and if there's any issues. And at one stage, when post his surgery, when he had the trachea and he couldn't speak, they were giving him a board to ride on, but he had very limited literacy skills. And these are all things that should have been checked prior to surgery, because they had no way of communicating with him at all while he had that trachea in. So that's when they stepped in with the audiologist that I had asked he be referred to. But yeah.
So
That's
thank
it.
you,
We're
Shannon
done. Yeah.
and Jay. I might just, Lara, just go straight to one of the quotes on the next sort of slides and down just to sort of wrap up. So here we've had 79 patients, 37 family people that we've supported in the program, a range of different cancer types, similar numbers of male and female participants, average age around 53, so much younger than the non-Indigenous population with cancer. Let's just go down, Lara, and we'll skip this one here and to the next here. And I just want to walk us through this because I think this quote from a family encapsulates sort of the whole navigation program. First and foremost, I want to acknowledge and thank you for the tremendous effort and support you've provided to the patient, to the family member and our family throughout her cancer journey so far. Your guidance has been invaluable in helping us navigate the complex process and addressing our concerns, and it's given them much needed comfort. Their ability as a First Nations cancer nurse coordinator to break down the medical terminology has been helpful, allowing them really to understand the patient's condition and their treatment options, but also enabling them to make informed decisions about what care they want to receive. And so from their perspective, this is from a family member, the continuous support is crucial throughout the whole cancer journey. It ensures that the patient and our family have a trusted and culturally sensitive advocate by their side throughout the entire process. Important part of that is building rapport. And so emotional and practical support that's provided by the navigator and advocating for the patient and the family has been extremely important throughout this journey. And because of the support and the roles, it's improved the quality of life and the journey of that patient, but also the family through these roles. And I think this sort of letter from the support person really covers and captures quite nicely the very complex and very diverse roles that our First Nation cancer nurse coordinators do. So thank you, Shannon, and thank you, Jay, and that's it for us. Thanks, Lara.
Beautiful job. What is so amazing is how similar many of our stories are from our patients. I see Nina nodding her head yes too, that with our Indigenous people, we truly are all related, and we deal with so many of the same challenges, and yet we have to address them differently based on what the challenges are in our local countries and in our geographies. They're doing something in the States, and I'm hoping it's coming out soon. It's actually from the Academy of Patient Navigators and Oncology Navigators, and they have an acuity measure. And this is to actually document how much time and effort navigators need to spend with their patient. And I was concerned at a meeting that was actually last May, and someone said that with well-trained navigators, the acuity should get lower and lower, meaning they don't need to spend as much time. And I said, no, our patients are incredibly underserved. When we do a good job, we will be spending more time and more effort for them to get to high quality and culturally respectful care. And I want to caution you that as they start to talk about acuity measures in your tool, that you continue to share with people who work with other population groups, that our goal is to improve access to high quality, respectful care, but we do not expect it to take less time. It is going to continue taking time for us to really address the issues our patients and their families experience. Absolutely beautiful. Comments or questions from anyone? Nina.
So the project could be to develop basic Indigenous cancer care coordinator competencies across our countries. We could kind of co-design a survey, then go and collect and analyse the data, and then come up with some core competencies. How about that for a fun project?
Yeah, we spent some time on competencies, and I think that what might, if we could modify it a bit to basically modify the competencies that have been identified in the states and how they have to be appropriate to Indigenous people. And I don't think it would take a whole lot, but I don't think it's worth the money to do a survey on it. I think that actually it's just like when Gail brought up, do we really need to go through and identify the cultural issues? We know the issues. We work in our community. We don't need a project on it. What we need to do is to help other people realize we need to go the next step. We don't need to go back and reinvent the wheel. We need to move forward. You all know what the barriers are and the challenges are in your community. But we need resources to have infrastructure and sustainability to address the resources in respectful ways. And similar with the competencies, competencies are fairly well established in the US. But how do those competencies need to be tailored to really be inclusive of our Indigenous programs? We have Gail, and then we have Kanita. Gail, next.
Yeah, thanks, Linda, and thanks, Nina. And I'm sort of wondering whether, in fact, because, even today's presentation and the other presentations that have, happened over, the last year or so with the network, there are some common themes that are coming out. And so I think we can pull those together. I know, Linda, you had emailed out earlier this year, I think, the competencies that came out of the US about patient navigation. What we could do is have a review of each of the different sort of navigation programs and competencies that are existing. If they're not existing, that's fine, but let's have a look at what they are. Let's scrutinize those from, an Indigenous perspective, pull them together. And I think, people around this sort of meeting and others that we've engaged with and you've been supporting over the years, we can pull together a very tight publication at a minimum, that then talks about these, because, for us in Australia, navigation is very new, and I want to be able to get in there very quickly, with some of these cultural competencies around navigation without redoing the wheel. There's information we know. How can we support each other collectively to then have our collective voice heard about patient navigation and some Indigenous competencies or components, but also understanding not that even though we're all Indigenous, that we're just not all the same, that there would be some variation, by different countries and that type of thing. So not trying to sort of put us all into the one group and label us in that way. But I think there are some common themes that are coming out even from today. So anyway, that would be my suggestion sort of going forward, if the group thought that was a good idea.
I think that's an excellent excellent idea. And I lost my connection to, and I think it was Kanita. You also had a question?
Yes, more so a comment than a question. Can you hear me okay?
Yes, you're wonderful.
So Cancer Care Navigation for some of our hauora partners has been going for about the last 10 to 15 years, if we're lucky. And what the lovely Robin, who's been visiting all of these Cancer Care Navigation partners around New Zealand, is hearing is that there is, we call them kai awhina, so as Cancer Care Navigators, they feel that their roles aren't valued. So they have, they have clarity and competencies through job descriptions, they have some cultural competency, love some more support in that area. But really, they feel that their roles aren't valued by the system or by more so the cancer system. And so what we're really keen on doing, and they also feel that they need more training in particular parts of their role. So what we're focusing on is developing some learning modules for cancer care navigators, and also looking at a career pathway and a form of accrediting their training so that they can feel that there is somewhere to go after they've started the entering in the cancer navigation role, but beyond that for them, but still staying close to cancer care delivery in the community. So at some point, I would really love to do some research in that space, or at least provide some resources in that area and work across our international colleagues and Indigenous spaces to look at those areas as well.
Thank you. And to let you know, we just submitted an article from our workforce development task group with the American Cancer Society on looking at levels of navigation and how job descriptions should be modified based on if you have an entry level, intermediate, or advanced patient navigator. Because so many times our navigators are being asked to do tasks that really they're not trained for yet, or that they're overtrained for it and they're being asked to do something in an entry level when they're advanced. And I believe we're close to having that article accepted, but it builds on what you just said, is that navigation has tiers and it goes from entry to advanced, and that people can have a very long and productive career as a patient navigator.
Exactly.
And some people think as a navigator that it has a ceiling, and it does not. And so that's one of the things that the task group has tried to promote with that. Shannon, you have your hand up. Yes.
I was going to say I was approached this morning by the nursing director for cancer services to tell me that they are employing, I'm hoping I'm getting this right, a First Nations cadet. So she's a second-year nursing student but has an interest in cancer. So they're going to be employing her within the cancer services, move her around a bit to give her an idea. Usually the second-year students are here to do OBS and things like that, but I've suggested that I also take her under my wing to teach her this part, because I think it's really important that she sees our mob going through cancer treatment and how as a navigator you can make, a difference in that space.
Excellent for her. The more you can shadow some of these young people, whether they're in the United States, we call them community patient navigators when they're not based in a clinical setting, but they're passionate in their role, very much how Nina and the Maori were talking about. A lot of their people, they may not be based in a clinical setting. So we have social work navigators, we have nurse navigators, and we have oncology patient navigators. And we really need all of the roles working together and being supportive of one another and how we move forward in a good way. I see people putting on their purses and their coats, and you have been amazing, wonderful things. I think we've got some good ideas. And I think we may actually have some of our next meetings be panels talking about some of these different issues and how we can support one another. We have wasted a lot of years, I think, in the United States, kind of fighting the system. And if we can find a way so that in Australia, you don't have to fight the system, you can get in and be respected in a good way, would be amazing. And to build off other things that we know are down the pike. So I'm going to be communicating with some of you one-on-one about, let's talk about training. And let's talk about alternative ways to handle training when you don't have resources. Certainly, and as Corey knows, because she works, she is within our program, we've been without salaries since COVID. Since COVID started, we are 100% volunteer, and we're looking at this new initiative from Medicare and Medicaid to do reimbursement codes. And we're jumping through hoops to try to find ways to sustain, in particular, oncology patient navigators. But we're having just as many issues with nurse navigators and with social work navigators. And so we have to find ways. And what I hope is with the next few months, we actually have some solutions. And if we can find solutions here, it might help you in how you approach your government and other funding sources. We've got to make these programs more sustainable, because in all the years of research, the commonality we have found that has led to successful interventions is well-trained Native patient navigators. Night and day difference. So I thank all of you for the good work you're doing. I know we're dealing with other issues in supporting our programs in each of our communities. But we will get there in a good way. Nina.
What would be cool is if we could share the evidence as well, you know, because when we're writing our funding, it'd be really good to get the evidence from the US and Australia and to have some like templates. Yeah, that would be really cool.
I can share that with you, as well as what some of our proposals are that have gone through higher up levels of where we're still missing, and we're going to create gaps if we don't get some of these things addressed now. Different gaps.
Yeah, let's get in. This is our International Indigenous Cancer Navigators Network on the screen. Let's share our stuff.
Absolutely.
And Kanita, we need a decop for this as well.
Yes, I think we do. But I would love for us to start collecting evidence. So we're very keen to get started on doing some learning modules, some training modules. So Linda, we're very keen to have a look at what evidence you've got. And again, you mentioned about a recent a new article coming out about the different levels of navigation, which I'm certainly interested in. So yeah, if we could find a way where we can drop a lot of that evidence, it would be great.
I will add in, we did publish one article in January that was about the levels of navigators, but the one that we just submitted is actually talking about how you would do job descriptions and how you have to base your job descriptions on the levels. That it's not, what's one thing to acknowledge there's levels, it's another thing to advertise and allow people to do the jobs they're trained to do based on entry level, intermediate, and advanced. Gail.
Yeah, thanks. Just earlier I think that was back in 2022, actually. I thought it was earlier this year. There was a publication out of Canada that reported on the role of Indigenous patient navigators, a scoping review. And that was out of Canada, and it looked at particularly at Canada, the US, Australia, and New Zealand. So it just basically was a report. What I think we're talking about and what was sort of missing there is this cultural connectedness, the sort of discussion that we've had today, which won't potentially come out of these existing publications, but I think we can have sort of, you know, an online sort of discussion about what some of these key things are and put them together in a report. Yeah.
Absolutely. And maybe when we do the panel talk from our different countries on how we're doing training, let's highlight what some of the cultural training is that we're doing in our respective countries to see if we can reinforce and help one another, make them stronger in a good way again. Yeah. Cool. Got more work ahead, but it's good work. And we're blessed to be able to work with the people we do. You know, we're on the right path. And sometimes we get frustrated, but we need to remember Creator put us here for a reason. And this is what we're supposed to be doing. Okay. So thank you all. And have good holidays. In the States, we have Thanksgiving holiday coming up in a few weeks. And we always like to remind people, remember the origin of the holiday. And that is that we fed the people who invaded our country. We didn't want people to starve. And we supported them and teaching them how to work in our communities. And we need to keep that thought and that philosophy in all that we do, that we support our people, but we don't let other people suffer unnecessarily either. So be happy, be healthy, protect your families, and I will let you know when we have our next IPEN. I do think it's going to probably be a panel discussion based on a lot of the ideas we brought forth, and it might be more than 2 panel discussions in the next year because we do 4 IPENs a year. When you have other ideas, just send them to me in an email. My email is my full last name, burhanstepanoff@gmail.com. And if you have other unique programs that you see in your country, let's highlight them and let people share what they're doing well so we can all benefit from what people are learning. Okay. Thank you all. Okay. Be well.
Thanks, Linda. Thanks. Bye, everyone.
Ka kite.
Take care.